we can manage our elderly patients better. With that, we shall move on to our last session with Dr. Premala. Let me introduce her a bit. So Dr. Premala will be our last speaker for today. She graduated from National University of Malaysia, UKM, for her first degree, and then she completed her MRCP under the Royal College of Physicians, United Kingdom in 2011, and then she completed fellowship in geriatric medicine in 2018. She is currently a consultant geriatrician in Department of Medicine, Queen Elizabeth Hospital. So we import her all the way from Sabah to be with us today to share with us on the topic of the important 3Ds: dementia, delirium, and depression. So how are we going to differentiate these 3Ds? How are we going to manage them comprehensively? So without further ado, I would like to invite Dr. Premala with her presentation. And please welcome.
Good afternoon, everyone. Slight correction. I'm no longer in Hospital Queen Elizabeth. I'm now in Hospital Raja Permaisuri Bainun, Ipoh, Perak. I think I just transferred over in the last 1 month. Sorry, Zana, I didn't look.
No problem, no problem.
I didn't realize I'm still based in Queen E. Right. Anyway, it's been a long afternoon session, so we'll just get on with it. The topic today is 3D. The D stands for delirium, depression, and dementia. So let's start off with the case scenario. So I have here Mr. C, a 76-year-old male. He's known to have chronic kidney disease in the last 1 year, hypertension and diabetes mellitus over the last 30 over years. He was admitted for progression of the CKD itself. He was symptomatic of uremia when he came in with nausea and vomiting. In the ward, noted that he was confused. He was refusing to eat and he had crying episodes. On further history, he's been forgetting to eat his medication, been forgetting to close the water taps at home, and has been getting lost while driving from his son's house to his own house in the last 2 years. The last 1 year, he had been having episodes of crying for no reasons with death wishes, and acutely altered behavior and with visual hallucination in the past 1 week. So on further history, when we asked Mr. C and his family, his wife passed away 1 year ago. So on examination, this patient was not attentive, he's not orientated, he was restless, he wants to leave the ward, saying his wife is there and he wants to go home, was irritable and did not respond to most questions. So these are the symptoms that we managed to elicit: altered behavior with visual hallucination, there were confusion, refusal to eat with crying episodes, death wishes, forgetting his medication, forgetting to close the tap, getting lost. So what do you guys think he's having? Is this delirium? Is this dementia or depression? So when we got back his results, his urea is high, creatinine is high, bicarb is 18, but all the other parameters were normal. The CT brain just showed cerebral atrophy. So remember that case scenario, later we'll go through it towards the end of the presentation. So what are the similarities that we see with the 3Ds? The 3 conditions can impact our thought process and our perception. It can affect our mood and emotions, and of course our cognitive functions like our memory, our attention, our concentration, affects behavior, affects our physical health, and also how well we are able to carry out our activity of daily living. What is the difference with the 3Ds? Of course, the cause is different. The symptom onset and the fluctuation of symptoms is going to be different. The level of consciousness will be different. The sleep-wake cycle is different. And of course, the treatment, because the cause is different. But can one person experience this, all 3 at the same time, or 2 at the same time? Yes. A person can experience more than one of these conditions at the same time. So I'm not going to touch about dementia again. Now we've been having 3 lectures already, isn't it? So let's go straight to delirium. So we're going to cover what is delirium, the types of delirium, how common is it, what are the problems with delirium, who's at risk, how do we diagnose, and the management. So what is delirium? It's acute confusional state characterized by disturbed cognitive function, perception, or consciousness. It is acute and it is fluctuating. Delirium is reversible. Dementia, from what Dr. Aslina and Dr. Low has been mentioning, it is irreversible. So the other name for delirium that we should actually say it out louder is acute brain failure. It is a medical emergency. Let me repeat this. It's acute brain failure. It is a medical emergency. Though we don't see the emergency of getting it diagnosed and treated in our own wards. Yeah? So the types of delirium that we tend to see is hyperactive, mixed, and hypoactive. And the patients that we tend to pick up having hyperactive delirium are the most commonest. Why? Because they trouble us so much during on-calls. They are the one who's shouting, the one who's aggressive, who wants to jump out, who wants to keep pulling out the rouse tube. So we pick up hyperactive delirium quite regularly. Mix is sometimes they're hypo, sometimes they're hyper. So that's why that group is called mixed. And we tend to neglect hypoactive delirium. You know why? These are the quiet old man and old lady at the end of the ward who sleeps and sleep. They don't utter a word. They don't say anything to you during rounds. And then they deteriorate. And then we do not know what happens. They end up with, falls. They end up with another round of infection, or they end up dying. So hypoactive delirium is the one that we usually don't pick up during our rounds, because we think these are the quiet patients at the back of the ward who don't disturb us, so we don't disturb them. But how common is this delirium? Yes, age is an important factor. It increases with age. But if you look at admission to the wards, medical admissions up to 15 to 50%, they have frequency of delirium is between 15 to 50%. When you come in with hip fractures, the frequency is higher. If you're more ill, you're in the intensive care unit, the frequency of delirium is even higher. If the patient is towards the end of life, you do see delirium. And compared to community dwelling, you see delirium more commonly in nursing home residents. Yes, we know that the numbers are high, but as I said earlier, the non-detection rates are even higher. So that means 1/3 to 2/3 of the patients that have delirium, we are not detecting them. So delirium is common. It is under-recognized. So we don't diagnose them and we don't manage them properly. So what's the problem with delirium? So, as I said earlier, the staff nurse will inform the medical officers on call, patient is jumping on the bed. So the risk of fall is tremendous. So we end up tying them up to the bed. So we make them immobile. So we will see functional impairment and decline. We will see prolonged hospitalization and distress. Distress to whom? To the patient, to the family seeing the patient being tied up, and to the doctors who are treating, because you're also wondering, why are you tying up this patient, right? And what is the potential outcome when somebody has delirium in the ward? The best is the resolution of delirium completely. The others are not good potential outcome, which is partial resolution, or there is long-term cognitive impairment, or this is actually goes into refractory agitation towards the end of life, and of course, death. So who is at risk to develop delirium? So you have to look at two factors. One is predisposing factors. The other one is precipitating factors. Predisposing factor is how vulnerable is the patient to get delirium. Age, previous history of dementia, previous history of delirium, they are frail, they are on 20 medicines, they are having sensory impairment, they are dependent on others to mobilize or to eat, they have history of alcohol abuse, or they have depression. These are predisposing factors, things that make them prone to have delirium. Precipitating factors are triggers. What triggers them? What tips them off into delirium? So this can be, infections, strokes, electrolyte imbalances, falls, pain, hip fracture, surgery for the hip fracture, and then you transfer them out from the ortho ward to the medical ward. So all these are the precipitating factors. So somebody who is vulnerable to delirium, they only need a small trigger to tip them into delirium. Somebody who has, who's not so vulnerable, they are young, they have low comorbidity burden, it takes a larger stress, a larger trigger to tip them into delirium. For example, let's look at this case. So you have an 80-year-old, fit, active, independent, still running marathon, noted to have chest pain, angiogram done, he's planned for CABG. So it's a major high-risk surgery. So the risk of him developing delirium post-procedure is still going to be higher compared to if he just goes for, if he just has UTI and oral antibiotics. So the level of stress in a robust older person is going to be different, and the risk to develop delirium will be determined by the stressor. Compared to somebody who has advanced dementia, all they need is a small trigger. For example, they are constipated because they are not drinking enough. So constipation is enough to tip them into delirium. So delirium often has a multifactorial etiology, but sometimes we cannot find a definite cause. What we do, we know it's a medical emergency, so we treat all the potential correctable contributing cause. For instance, patient's pain score is 4 to 5. He also didn't BO in the ward for the last 3 days. It's coming in with AGE, so he's having diarrhea. So you have already identified almost 3 factors. Probably dehydrated, he probably has some electrolyte imbalance, or he's probably, he can't be having diarrhea and constipation, right? So probably electrolyte imbalance, he's having dehydration, and he's in pain. So if we treat all these 3 potential cause, we may be able to reduce or prevent delirium in the first place. So how do we diagnose delirium? It has to be a disturbance in attention and awareness. And it has to be the disturbance develops over a short period of time, and there must be a change from baseline attention and awareness, and it tends to fluctuate in severity. There has to be another disturbance in cognition where there's either memory deficit, they are disorientated, or they are having some hallucinations. And criteria A and C is not explained by any other diagnosis. And there is evidence from the history or physical examination or laboratory finding that this disturbance is a direct physiological consequence of another medical condition. That means it is triggered by something else. So how do we assess delirium in the ward? There are many methods. As long as you pick one, you understand how to do it, and you know the limitation and the advantages of doing a screening tool, then you can proceed with one. So my favorite is to use CAM scoring, because one, sensitivity is high, specificity is high. The next one is rapid assessment test for delirium. Sensitivity and specificity not too bad. So what is CAM scoring? CAM scoring says that the patient has to fulfill 1 and 2, which is acute onset of fluctuating course together with inattention, and or number 3, +-4, disorganized thinking, altered level of consciousness. So for us to diagnose somebody with delirium, their marks has to be 3 or 4, and they have to fulfill number 1 and number 2. So how do you detect inattention? Is the patient able to follow our conversation and able to answer appropriately? If they're not able to, are they distracted by unimportant things? Yes, then that means they're having inattention. Do they have disorganized thinking? You know, you're telling them about A and B and they're answering you about E and F or X and Y. So they don't have a proper flow of thoughts. And of course, number 4, altered level of consciousness is whether they are hyperactive or hyperactive. So why I like to use CAM is purely observational. That means you can see the conversation between family members, between nurses, between your junior doctors to them, for you to be able to score their CAM. The 480 is assessment that you need to talk to the patient. So if the patient is able to talk to you, they have no aphasia, then you can do this 480 directly. So you look at alertness, you look at their, you ask them few questions about their age, date of birth, name of the hospital you're in, what's the current year. Also check the attention by asking them to name the months of the year backwards. Can anybody volunteer to try now? Okay, so try it quietly, and then you can tell yourself whether you are paying attention to my talk or you're already having inattention, because we are having a long talk today, right? So the next one is acute changes of fluctuating course. So when you have score of 4 and above, there is a possibility of delirium. So this is the 480, the assessment tool. So what's the principle in managing delirium? So first we need to prevent. If it hasn't occurred, we have to prevent. If it has happened, we have to recognize. Then we treat, then we support, and then we prevent complication. This is the main principles of managing delirium. Prevent, recognize, treat, support, and prevent complication. So how do you prevent? So you already know which patients have predisposing factors for increase for having delirium in the ward. So for all these patients who are at risk, ask about pain, ask about constipation, see whatever catheter that is attached to them. Do we still need those catheters? Do we still need that oxygen tubing? Do we still need the CBD? Look through their medication, whether there's any of those medication that is making them more confused. Is there too much of diabetic medication making them to have hypoglycemias in the ward? And avoid unnecessary sedation or antipsychotic or anticholinergic in your new prescription. These are physical prevention. Environmental, try not to shift them, from bed 1 to bed 2 and then go to bed 5 and then come back to bed 1. So that would reduce the confusion towards the environment. And number 3 is for cognitive and social. If possible, pre-COVID, what we tend to do is bring the family members over, so they have somebody that they can recognize, and the family members can help our nurses to look after the patient in the ward, especially when they are confused. Do not argue with the patient, and then try to cognitively stimulate them at the point of the day where they are the brightest. So your nurses or the family members can tell you, I think in the morning he's the brightest, he is most alert. So in the morning, we try to get the physios on board. We try to, orientate them to place and person and explain to them why they are there in the hospital and why they need certain tubes. there's no point trying to stimulate them when, when they are already confused, because this confusion in delirium fluctuates. So we catch them when they are the most alert to give them cognitive training. So Inoue has done a study many, many years ago. They have come up with this 5 areas to prevent delirium in the ward. So we look reorientation aids at home to bring them from home and pass it to the patient, to avoid sleep disturbances, and to ensure there's some sleep hygiene being carried out and make sure they don't nap during the day. Number 4 is to look at their hydration and encourage oral intake as much as possible, and to encourage early mobilization and minimize the use of catheter and restraint. Just by looking at these 5 components, and the interventions are it's not high-fi intervention, we are able to actually reduce the delirium almost by 5 to 6%. And the length of delirium has been shortened by almost 2 months for those patients involved in this study. So the next part is to treat delirium. So I mentioned earlier, there are predisposing factors, there are triggers. Identify the triggers. If you think the trigger is a urinary tract infection, let's get that sorted. If you think the trigger is pain, let's get the pain settled. If you think the is electrolyte imbalance, let's correct the electrolytes. So find the trigger, identify the trigger, and treat. And of course, we have to support while waiting for the delirium to resolve in the ward. Again, management of behavior in a person who's delirious. How do we manage? We need to observe, we need to reorientate. We need to know who is this person sitting in front of me and why is he confused. I had patients in HKL before. Every day at 4 o'clock in the evening, he will start spitting and he'll start throwing water at whoever who's walking by his bed. We observed this behavior for 3 or 4 days. We had no clue what was happening until one day, a fine nursing student offered him food at 4. And since he managed to get the food, we didn't see the behavior that day. Then only we realized that actually he gets his tea in the hospital at 3, but he's not able to take the food prepared for him. It's too far away. So he was, throwing water. He was spitting at whoever who's walking by because he wanted attention. He wanted them to give him the food. But because of the lack of communication, understanding, we missed the first 3 or 4 days because we didn't know what was his need. And of course, if he had a family member at that point in time, it would have been more effective. We could have prevented, that few days of drama in the ward. Of course, as doctors, we find antipsychotic very tempting. But you must understand the indication to put them on antipsychotic. As Dr. Loh Choo Ming has mentioned before, antipsychotic has a black box warning of increased CV events. So the indication must be appropriate. So what's the indication? If you want to carry out essential investigation on treatment, yes. If the patient is endangering themselves or others, yes. If it's to relieve the distress in a highly agitated patient, yes, those are the indication to put them on antipsychotic. But make sure when you start, you review the medication again and again. Discontinue as soon as possible and use one drug at the minimal dose that is effective. And which antipsychotic? There's no correct answer. Different institution, different setting use different regimes depending on the local preference. So you just have to look at the institute you're on and see what is the usual drug. So you just make sure you're giving the appropriate dose and the appropriate method, whether it's IV, IM, or oral, and then take it from there. So these are the types of antipsychotic and BDZs that we can give. And if for somebody who has refused oral options, these are our IM options. How about physical restraint? Should we restrain our patients? Do you think the delirium is going to get better or worse? So I always tell my MO when they tie up the patients in the ward, let me tie you up in the ward and let's just say that you have an itchy nose and you can't scratch your itchy nose and you're being tied. Are you going to be calmer or you're going to get more distressed? Of course, you're going to get more distress because your nose is itchy. You can't scratch your own nose because all this healthcare worker have restrained you. So physical restraint doesn't resolve the distress. It usually aggravates the emotional distress and disturbed behavior. So it should only be used if less restrictive measures seems to be ineffective. And when you use the restraint, please monitor for complication. And restraint should be limited in 24 hours. And after 20 hours, you need to re-evaluate. So when we talk about restraints, there are many types of restraint. Whether you tie both the hands up with the abdominal guard, or you just tie the legs and the hand like this, or you put them on a mitten, or you put up the railing, or you confine them to a wheelchair, or even a geriatric chair. So these are types of restraint. So when you put them on restraints in some hospital, like Hospital Queen E, we do have restraint monitoring chart, whereby it is written that the restraint is ordered by whom at what time and was carried out by which nurse, what's the indication, and whether the family has been informed, and which type of restraint. This is important for medical legal reasons. So how do we minimize the devices that we put in for the patients when we think is indicated? For example, quite common is our NG tube. So when you see somebody with NG tube and they are in distress because of the NG tube, they keep removing the NG tube. So we need to see whether the need and the indication is still present on the day of your review. If it's still present, probably we can get hold of the speech therapist early to do a swallowing assessment and see whether we can restore the oral feeding with or without modified diet. And of course, for some patients, it's just unfortunate that we are not able to take off the Rouse tube. So we need to put an anchor it properly to prevent pressure injury. And same goes to IV access. IV access doesn't have to be, you're giving them IV drip 2 pints over 24 hours. If the patient is delirious towards the evening, maybe we can complete the 2 pints in the first 8 hours of the day before the behavior or the confusion gets worse. You can even consider, giving them boluses. And once you are done for the day, we can actually consider Hapalok with bandage and keep the IV line out of the visual field. So either you put it under the gown or, put it under the sleeve so they cannot see, so they don't remove. Or consider alternative like oral fluids or subcut fluids. Bladder catheters. Again, same thing. Everybody who comes to ED tend to get a bladder catheter. So when you see them in the ward, we have to see what is the need, what is the indication, can we get away with alternatives like condom or a urinal. Maybe we can go for time voiding program, or just put them on diapers if you don't need to monitor the in-out strictly. So these are the usual medical devices that may trigger delirium in the ward. So how do you recognize delirium? As I said earlier, delirium is common but is under-recognized. So when we don't recognize, we don't diagnose. When we don't diagnose, we don't treat. So some tips to recognize delirium is you as a doctor who's treating the patient, you feel frustrated when you assess the patient. And your housemates will label them as poor historian. The nurses will say, oh, they're confused at night, they're jumping on the bed. And you know, when you see them, they're sleeping throughout the day. And the moment you leave the ward at 5 o'clock, the patient wakes up and, you know, cause a terror at night in the ward for the night houseman, night MOs, and the night staff nurses. And if you look at the reviews, probably somebody prescribed haloperidol over the phone and they can't be discharged because there's just something not right with the patient. So during the day, when you're seeing them at 8 o'clock, especially with the pakar or with the consultant, they are like, you know, the top gremlin. So good looking, so kwai. But then at night, then they become the terror. Okay, so this is how to recognize delirium. Are you guys okay?
Yes, Dr. Premala, please
okay.
go ahead.
Okay, all right. So go on to part 2, which is depression. So these are some of the topics that we'll cover lah. Yeah. Okay, so what is depression? It's a cluster of symptoms that is present on most days, most of the time for at least 2 weeks. And the intensity of the symptoms are out of ordinary for individual. But the good thing about depression, it is treatable to cure. So when you look at the National Morbidity and Mortality Survey done a couple of years ago for Malaysia, 3 out of 10 older persons are unhappy in Malaysia. And 1 in 10 of them are having depression. So of course, the prevalence are higher in women compared to men. And about more than 20% are found in hospital setting and up to 40% in long-term care. The problem with depression, it is also associated with high risk of suicide. So the suicide risk factors for older person in depression is when they are advanced age, when they don't have social support, they are widowed or divorced, they have recent losses, they have medical illnesses, if they are male, if they have attempted before, if they are abusing substance, these are the risk factors for suicide. And the worst thing for older person is they don't come in typically. They will have all the atypical presentation, not only for depression, but for most medical illnesses. When they come into ED, they come in with atypical presentation. So for depression, they may come in with weight loss. They may not tell you that they are increasing the alcohol intake, or you know they're smoking a bit more. They may tell that they are having problems sleeping. Do you have any sleeping tablets for me? So they may come in with fatigue, they may come in with anorexia, and they may not be wanting to do or continue with their hobbies. So when they come into you with these symptoms, you need to have a high index of suspicion whether this is depression or not. So which older person has a high risk to get depression? They have to be usually female. They have a lot of somatic illnesses, pain here, pain there. They usually have sleep disturbances, may have some personality traits, or they had previous history of depression or diagnosis of dementia. Some of them with restricted mobility may have higher risk of getting depression. Those who are divorced or have loss of loved one, or even any kind of losses like, stop working, so they have financial difficulties. So these are the risk factors that can increase, make our patients to have a high risk to get depression. And of course, when they're confronting with their own mortality, the risk of getting depression is also high. But doctor, everybody who's 80 years old will lose somebody that they love. Yes. So how do you differentiate depression and grief? You have to understand, losing somebody that they love, especially their spouse, it is It's sad lah, kan? Your spouse have been your partner for the last 40 years to 50 years, and suddenly that this person is missing in action. But grief is a natural process. Yes, there is intense sadness. Yes, you're withdrawn from your usual activities, but your self-esteem is maintained. And when you think about this loss of loved one, the painful feeling will come in waves. But you don't get all negative memories. You will have also intermixed with positive memories. And oh, of course, you also think about dying, but you think about, when can I join my loved one? You fantasize of joining with your loved one. This is grief. But depression is pathological. There is intense feeling of worthlessness and self-loathing. The focus on ending one's life is not because you want to join the dead spouse. It's actually because you think you are worthless, undeserving, and unable to cope with the pain or depression. So this is depression. It is different than grief. So for some people, they accept grief up to 4 to 6 weeks after loss. And if the feeling of sadness is still intense and there is reduction in activity of daily living, they may be considered into depression, and then we will screen them for depression. Yeah. So how do we diagnose? It has to be 5 or more symptoms nearly every day for the same 2 weeks. Okay. So you can use this mnemonic, which is AD to SIG, E caps for depression. A and D is a must. Is anhedonia and or dysphoria, plus 3 or 4 minor symptoms, which is changes in sleep pattern, reduce in interest in doing your normal activities, increased guilt, reduction in energy, reduction in concentration, changes in appetite, the psychomotor reduction, and the increase in suicidal thoughts or ideation. So how do we screen? I know that you sit in a busy medical clinic, so we have 2 questions of screening. If they answer yes to either one, then yes, you have to do a proper assessment. But if they say no, then you can skip and go on to the next topic. So in the last 2 weeks, you have to ask your patient, in the last 2 weeks, have you been bothered by feeling down, depressed, hopeless? Or have you been bothered by having little interest or pleasure in doing things? Okay, so the sensitivity for these 2 questions, 100%, specificity is 77%. If they answer yes to either one, then please proceed. Either we use a geriatric depression scale where more than 5 and more is diagnostic, or if the patient has dementia, then we can use the Cornell scale for depression in dementia, and more than 12 is a probable depression. The reason why we need something more objective is if we do think that the patient has depression, we are considering them to be on pharmacological drugs, then we need something objective to monitor their response and the resolution of their disease. But before we go on to pharmacological treatment, we have to see whether is there anything else happening? Is there any medication that is causing them to be having low mood? And for laboratory tests, there's no consensus which test should be obtained, but these are the basic tests that we do. So again, depression is a hidden illness, it's underreported, and it is masked by dementia, masked by comorbid illness. There is a stigma associated with aging, there is stigma associated with depression, of course, cohort effect. So how do we treat? And what are our aims of treatment? We want to improve their mood. We want to improve their function and quality of life. We want them to recover and prevent future episodes. And the intended outcome should be complete resolution, not only reduction of symptoms. So how do we treat? We have medication, we have ECT, psychotherapy, or in combination. So how do we choose antidepressant correctly? So we have to see whether this is the first episode of depression or multiple episodes of depression. If the patient had previous episodes of depression, see what is the response to the previous treatment. what is the side effect profile? What are the interaction of the medication in antidepressant and all the other medication that they are taking, and whether there's any potential for lethality of overdose. As usual, as what Dr. Azina has mentioned earlier, start low, go slow, but please reach target. Okay, start low, go slow, and reach target. Okay, so for older person, usually we can start at half a dose of a younger person, and we have to reassess the adverse effect and the resolution of symptoms. So these are the many types of antidepressant available, but SSRI is usually the first line. Why? It's more effective, it's more tolerable, and we have fewer side effects, especially the anticholinergic effects. But the SSRI side effects that we tend to see, that's the mnemonic, headache, agitation, anorexia, nausea, diarrhea, sleep loss, and hyponatremia. And thus, that's the reason why we need to have a baseline sodium, and we will repeat the sodium levels few weeks down the line, right? For persons with depression and issues with sleeping, please do not serve the antidepressant at night. Serve it in the morning, so they are not sleeping during the day, and they are able to at least sleep better at night because they are already so tired. The next one is psychotherapy. Of course, this is meant for patients with mild to moderate depression. It is comparable with effectiveness of antidepressants. So types of psychotherapy is CBT, interpersonal therapy, and supportive therapy. So what if there is no remission? You have started the patient on psychotherapy, you have started the patient on antidepressant, but we don't see any remission. So you have to see whether we have reached target, whether we need to add on medication, or whether we need to change the antidepressant. About 2/3 of the older person, they don't go into remission. So please know your limit when you're managing depression in your medical clinic. And if need to, please get the psychiatrist on board. So this is the suggested algorithm. So whether this patient has received antidepressant medication, whether they are in remission. If this is the first episode, after a year, we can think about gradually tapering off the antidepressant. If this is second or third, we may want to extend the antidepressant for a longer period. If they don't show any remission at all, consider continuing the antidepressant. So back to Mr. Fredrickson. Okay. In the ward, when we did the CAM scoring, he initially scored 4, 3, 3, and by day 4, day 5, his delirium has settled because the score has already gone down to 2 and 1. So after that, when we reassess, we found that he does have forgetfulness of immediate and recent event. He does have low mood, loss of interest in daily activity, and he been wishing for death to occur soon. But on examination, he was conscious, he was cooperative, he was orientated, but he still looks sad and depressed. When we did the MMSC, at this point in time, his MMSC was 14 and the GDS was 7. So antidepressant was started, and during follow-up, about 3 to 4 months after discharge, he no longer has delirium and the GDS has improved. His memory component, the memory has returned to baseline, whereby he still has short-term memory impact, and he has executive dysfunction. MMSE was 18. So after discussion with the patient and the family, a trial of donepezil 5 mg was started for his dementia. So when he presented to the ward many months ago with the progression of the CKD, what he had was delirium with a background of depression and dementia. So delirium, we settled it because we have managed to identify the trigger. We treated the trigger, so delirium has been managed. Then we detected the depression. When we treated the patient for depression. The memory improved slightly. Not sure whether it's the resolution of the delirium or the treatment for depression. But his baseline MMSE is still 18 and there is still impairment in short-term and executive dysfunction. So he also has a diagnosis of dementia, probably AD. Okay. I'm not going to go through this. These are the differences between the 3Ds. I think we have gone through this. All right. So any questions?
Thank you very much for the presentation, Dr. Premala. Any questions from our participants, either through the chat or if you want to ask directly, also not an issue. More than welcome.
I think everybody is inattentive already. Kena buat camp scoring dah. Yeah.
Oh, yeah, one question coming.
Okay. I spoke too soon.
Okay, question by Kim in the chat.
Yeah. Yes, some side effects, some medication has different side effects. Let me see. Okay. So if you look at antidepressant, you will find and look at their adverse events. So some medication will cause both insomnia and also cause somnolence. We do not know which patient will react which way to the medication, right? But if the incidence of somnolence is higher, for example, patients on mirtazapine low dose, it causes more sedation and patient has sleeping problems. So I tend to serve the mirtazapine 15 mg at night because I also want the side effects to help on the sleeping problem. Okay. Certain doses like mirtazapine 30 mg causes insomnia. So I do not want to serve the mirtazapine 30 mg at night. I want to give it in the day so they are more wakeful during the day so I can do more activities. This is mirtazapine. So for the other SSRI or SNRI, we have to see what is the prevalence of the side effects, whether it's causing more somnolence or it's causing insomnia. So if the medicine is causing more somnolence, patient has sleeping problems, then I want to give it at night. If the medicine causes insomnia, patient has sleeping problem, I don't want to serve it at night, I want to serve it during the day. Yeah. So for Luox, I'm not sure. We have to look at the medication and look at the prevalence of the adverse event, whether it is more it causes more somnolence or insomnia. And again, not everybody reacts to the medication as how it's mentioned in the medication prescription list. So if your patient, once you start them on certain medicine, we have to call them up and ask them whether they are having any side effects and change the timing or change the medicine based on the severity of the adverse event. As I think I didn't mention earlier, anybody who we start with antidepressant, the risk of suicide actually goes up earlier with the treatment. It means how the first few weeks, the risk of suicide is higher. So we actually need to either give them a call or see them back in clinic to see whether there is increase in suicide ideation or attempt or thoughts, so we can address the matter before they take the next step. Okay, the next question is blood thinners, cardioprin and SSRI. Okay, Lydia, if only money is never an issue. If only money is never an issue. Compared to SSRI and mirtazapine is more expensive. And SSRI is a bit more cheaper. Of course, the side effects are different. So cardiprine and SSRI, yes, there is increased risk of interaction, but number one, not everybody has that interaction. Number two, we have to see the indication for the cardiprine and the indication for SSRI, weigh between the risk and benefit. And again, communication, when we start any new medicines for the patient, tell them these are the side effects I am anticipating. If you do develop the side effects, please get back to me as soon as possible so we can help me to monitor, so then we can detect and then we can stop the culprit. I have no experience in prescribing agomelatine. I tend to use more SSRI or mirtazapine in my center, so I cannot comment on the agomelatine. Sorry. Okay, I hope I answered your question, Lydia. Okay, so for Hamiza, how long can you anticipate improvement with antidepressant and donepezil in a patient who has both disorder? Okay, so depression, the other name is also known as pseudo dementia. Okay. So for somebody who has both disorder, and I have one disease that I can cure, which is depression, and I don't have a cure for dementia, I tend to treat the depression to the optimal dose and monitor the resolution of the depressive symptoms, and also have a look at the improvement of the cognitive function. So you have somebody at the beginning, you're not sure whether you're dealing with depression or dementia, or whether they are playing the parts together. So I'll treat with antidepressant first, see whether there's any improvement, whether the depression resolve, and at the same time, see whether the memory improves. If the memory improves to baseline, so and the patient has no cognitive impairment, that means we have only dealt with depression that acted like a pseudo dementia. So then I don't have to treat the dementia. Just say I treated the patient for depression, there is memory improvement, but there is still impairment, like our Mr. Fredrickson, he still had short-term memory, he still have executive dysfunction. That means he is having both conditions present. So I know my depression, I can treat it to cure, but my dementia, it is an ongoing process. So usually we will see them back in our clinics if it's for after initiation of antidepressant, if there's going to be a phone call, no side effects with the medication. So we tend to see them back at 3 months or 2 months, and then we will repeat back the MMSE and the GDS and to see which way we are going. If cognitive improvement is full just purely with antidepressant, then we'll see them back in, every 3 to 4 months, look at the MMSE, GDS, and then we just take it from there. If the depression has settled, but the dementia is still ongoing, and I don't see any BPSD symptoms, the other medical conditions are fairly under control. So I may see them back every 4 to 5 months and just monitor the MMSE and see whether patient need one cognitive enhancers. And if they are a good candidate for cognitive enhancers and we can start them on cognitive enhancers without any side effects, then I will start them on a low dose, monitor for side effects. If they are tolerating, after 2 to 3 months or 1 month, we can push up to full dose, observe again for side effects. If no side effects, maintain the cognitive enhancers for 6 months before we sit down and talk to them and see whether they actually benefit from the cognitive enhancers or not. Because as you know, not everybody responds to cognitive enhancers. Some they respond, some they have respond, but they have side effects, and some there's no side effects and they don't respond. So for the third category, after 6 months of full dose of cognitive enhancers, if there is no improvement, patients saying, I don't see any improvement, the family is saying, and you're also saying that there's no improvement, then we may stop the cognitive enhancers after 6 months on full dose. I hope you're clear with my explanation.
Yes. Good
Yeah.
and detailed explanation. In fact, there's a couple more questions for you there. Premala, we can see. I guess I close with that 2 questions. Just try to answer perhaps in short. One is by Lydia regarding if you need to recommend one sleeping pill.
Okay lah, Lydia, if you have worked with me or been under my service, my MOs will roll their eyes if I say, if I mention sleeping pills, because I think I've never prescribed any sleeping pills when I was in KK, except for 3 patients over 3 years or 4 years of service. I've never prescribed because one, I have seen a patient going into withdrawal from BDZ, and it was not a good experience. So I stay away as much as possible from initiating sleeping pills to anybody. So that was one patient. So this patient was an ex-nurse who's been getting her sleeping pills from her GPs and her normal doctors from the hospital. And when I saw her for the first time, she was confused. When we admitted her, we noted that she was confused. There are many things happening, and the doctor comes to me and tells me, "Oh, doctor, these are all the sleeping pills I found under her bed." And we had no idea what was the dose that she takes on a normal day, because she's already confused. So we had a lot of problem bringing out of that delirium now. So that was one experience that I do not want to make anybody else go through. So I stay as far away as possible from sleeping pills. That's one patient. The second patient that I had to continue the sleeping pills is somebody who's been dependent on BDZ for the last 15 years. Every time we cut down the BDZ, he will come in with more somatic symptoms. From diazepam 15 mg on night, after I think over 6 months to 9 months, we only managed to cut it down to 12.5 mg. But we managed to stop all the other medicines for him, which is still a success for me. So for the second patient, he ended up with renal cell carcinoma. He underwent a nephrectomy, so diazepam was not a good option. So that's the first time that we actually put him on non-BDZ, which he didn't tolerate because he was actually dependent on the diazepam. So after these 2 patients, I stay far away from sleeping pills. My first line of advice is always sleep hygiene. I think Dr. Loh has mentioned it casually about sleep hygiene. The bed is only meant for sleeping, so no phones, no reading on the bed. And you need to create a routine on daily basis, 3 or 4 hours before sleep time, so your body knows after this is what, after this is what, and the last activity for the day is to sleep. So you need to create a routine. If I have no choice and have to put them on something, then probably I would go for non-BDZ. If I have no choice, I would go for non-BDZ, probably zolpidem. Yeah.
All right. Thank you very much, Premala, for the extensive input.
Okay, Adrian asks if the patient is on maximum dose of donepezil and memantine and still yet the memory loss is severe, what can be done? So, Adrian, I've always said that dementia, especially Alzheimer's, I have no cure. The disease is a progressive disease. The medication that we put them on, the cognitive enhancers, are only going to maintain them at where they are for a longish period. And as the disease progresses, the medicine has been on maximum dose and it won't be effective towards the later part of the disease because the disease is still progressing. So I think when we are breaking the bad news of breaking the diagnosis of dementia, especially Alzheimer's, we have to stress on this part that this is not a cure. It is only going to buy time. We want them to be as independent as possible, as long as possible, as long as the medication is working. So as I said earlier, for patients who are on cognitive enhancers, 6 months on maximal dose, if I don't see any response, I'm going to just stop them, right? So the same thing goes for patients who initially responded to the medication, but as the disease progresses, there'll be a point where the disease is not going to respond to the medication. And at that point in time, you can actually talk to the family and see whether there is, whether we could actually start tapering off or stop the medication altogether, because the disease has progressed beyond the ability of the medication to assist the patient. Again, you must understand when the patient is put on cognitive enhancers, if they're coming in with repetition, the medication does not take away the repetition. It is only going to make patient more aware of the surroundings. So hopefully they can interact better and they can pay attention and they, they are able to carry out their activity of daily living. It does not reverse whatever that has been lost. So what can be done when the patient is on maximum dose and memantine and donepezil? What can be done? Yes, at this point in time, non-pharmaco intervention is ideal. The family must understand and we must educate them and we must support them through their journey, right? So if they are dealing with a lot of BPSD symptoms, so then we have to identify which are the stressful symptoms. And as Dr. Chuming has mentioned, not all BPSD symptoms need to be treated. For example, if they are having visual hallucination, but the hallucination is bringing them joy, they are seeing their parents, and they are happy looking at their parents, you don't have to treat the hallucinations, yeah? So at this point in time, when medication is no longer helpful, then we go for non-pharmaco. We need to support, we need to discuss with the family regarding ceiling of care and whether, we anticipate more deterioration in near future, whether it's increase in falls, whether it's going to be aspiration pneumonia, UTI, constipation, poor appetite, weight loss. So we need to address all that with the family.
All right, thank you very much.
Thank you, Cheng CM, for giving us the, what is that? For giving us the dosing for the sleeping pills.
All right. Okay, thank you very much, Dr. Premala, for your extensive input. Very beneficial, and I believe all of us gain a fruitful discussion and information that we will bring home. With that, we are at the end of the session.